Hello everyone, welcome to another edition of Inside Talk. Today we're at the Schultes Clinic in Zurich and we're meeting with Dr. Daniel Herren, the chief of the hand department. And we're going to talk with him about the touch prosthesis from KeriMedical, the dual mobility trapezometatarsal prosthesis. And now we're waiting before Dr. Daniel Herren finishes his surgery because that's ongoing right now, and I think it's almost come to a completion. Yes, he's coming. Hello, Mr. Dr. Herren, nice to meet you.
Nice to meet you too.
So first of all, we'd like to know, how did the surgery go?
The surgery went very well, actually, as planned. However, in this particular case, we had to prepare a bit more of the soft tissue than expected in order to really mobilize the joint the way that we could place the, especially the cup, adequately. But it went very well. I'm happy. The X-ray looks good.
I'm glad to hear this. So with your department, you placed almost 400 of these touch prostheses. What is the advice you would give to a young colleague who is preparing for his first surgery?
Training. I think it's very useful first to do a cadaver lab training, then see surgery, and then do first surgery under instruction. I think this sequence would be ideal. There are some tricks, and I think it's really worthwhile, and the learning curve is much steeper if you really follow those tricks. So please use the possibility of getting trained.
And do you have a specific or a preferred approach, volar or dorsal, or does it depend on the X-ray or in the patient situation?
No, on a standard basis, we are going to the dorsal approach. That's most of my colleagues. It's the easiest way to approach the joint. And I also think anatomical-wise, it makes most sense.
The trapezium is a very small joint. And if you have a small stature patient, it might be a bit tight, you know. Do you see that on the X-ray already, and if not, what is the approach or what is the alternative during the surgery if it gets too tight?
I think on surgery, it's important to measure before, in order to plan it, the height of the trapezium. That's the most critical point. We need a certain height, which, according to the books and the literature, says about 8 millimeters of height. Sometimes it can be even less. If you have a really small trapezium, it might make sense to use a conical cup, because the conical cup, you can let it standing out a little bit, and you don't have to put it in as deep as the spherical one. And this can be a good advice, in especially not very height, not a good height of the trapezium.
And interestingly, you also, from the right from the beginning, you planned a registry here at the Schultes Clinic, and so you monitor every case and the outcome of it. What are the learnings out of this register?
We started the registry quite a few years ago, and we are collecting all data of all implants we are using around the hand, and it's a treasure. It's a treasure in this regard that we have a follow-up registry with data, real data from our patients. So it helps us to follow up the patients, to see the results, comparing results between different techniques, different implants, but also different surgical approaches, for example. And based on this, we can do a lot of scientific work, and it really helps us to improve our standard surgical technique.
And maybe coming or insisting a bit on the results, on the touch prosthesis, because that's a general concern I hear from time to time, that over time the prosthesis must be long-lasting, and how long do they last? What are the outcomes here? Are the success rates stable over time?
I think it's extremely important, implants being implanted to last as long as possible. We know that from the hip and knee, because the implant survival should be nowadays between 15 to 20 years or even more. We have some data from the generation before, because especially the touch prosthesis is not that long on the market that we really have a lot of long-term results. But we assume, since there were a few modifications on that generation of implant, that at least the results of the generation before will be reached. And what we see from the third generation of implants, the survival rate after 10 years is around 93 to 95%, which is very impressive and which is extremely close to what we have in the hip. And nowadays, nobody would discuss the issue about how long lasts a hip prosthesis. And, you know, you have to have revision options. And I think that's an important thing as well. So if you have good revision options, you are also more relaxed to put an implant in, which probably has not that long of a track record.
Okay, that's very promising and good news. And what are the alternatives? So if in the case of these 5 to 7% something will go wrong, are there alternatives for the patients?
Indeed, they are, and they are good alternatives. You know, the standard procedure still nowadays in most countries is the so-called resection arthroplasty, where you take out the trapezium and you replace it with a tendon or some soft tissue into position. And you can always do that after an implant arthroplasty. But I think it's also important to mention that most of the time when we have problems with the cup. And cup revision, cup changement is still possible. So it doesn't mean if we have a problem with the implant, we directly have to go to the resection arthroplasty. We have to analyze the problem and taking then the decision which is probably the best revision option in that particular case.
My brother works in construction. He's a bit of overweight, I apologize for that. But he has a relatively good bone quality. Would you still recommend the touch prosthesis for him?
How old is your brother?
He's about 51 now.
You know, it depends on the osteoarthritis, as I already said, you know. And for him, there would be 3 options: osteotomy, fusion, or joint replacement. I would never go for a resection arthroplasty in such a young individual with high manual demands. And depending on the rest of the wrist, the X-ray, fusion might be an option in such case as well. So again, you have to discuss with the patients the pros and cons of the intervention and what he has to expect also in terms of what are the revision options in the future, and then make a decision, shared decision together.
Okay, and the touch prosthesis is often compared to a mini hip prosthesis. You also mentioned it. Is that comparison fair? Is it adequate?
It depends. If you look at the mechanical principle, it's a mini hip. It's true. Yeah. Because you have a cup and you have a head which is moving inside. Mm-hmm. What we have is double mobility, which we also have in some implants at the hip as well. Anatomical wise, it's not the same. And also in terms of forces, it's not the same. But interestingly enough, although we have a saddle joint in the thumb basis, it seems to work very well when we replace it with a spherical, just a moving part of implant as we have in the hip. So it's interesting that it works, and it has been proven that it works well mechanically.
Maybe for the surgeon, what are the advantages of a touch prosthesis in comparison maybe to a trapeziectomy?
Oh, we could show, and this is very well known also in the literature, but it's really impressive. When we started to do that 5 years ago, we couldn't believe how the patients looked like and how their thumbs looked like in the first post-operative control we had. You know, they came in, no splints, they didn't have any post-operative medication for pain, most of them. They used their thumb quite normally, and they were extremely happy. We never have that in the resection arthroplasty. It takes much more time for rehabilitation, so that's point number 1. Point number 2, the function is virtually normal. Mm-hmm. I never had an intervention in the hand which patient told me, "Doctor, my thumb feels like nothing happened. It feels like when I was 20 years ago." So very interesting. It seems that we give back quite a normal function. So that's number 2. And then what we clearly could show is increase of force and strength. That's very impressive. Resection arthroplasty, again, takes a long time, up to 6, even longer months, in order to really have enough strength for doing activities of daily living, which we have same results after 4 to 6 weeks in an implant arthroplasty.
Okay. Thank you very much, Dr. Daniel Herren, for all this insight. And you, dear listener, thanks for tuning in and hope we'll see each other again for the next edition of Inside Talk.